We are pleased to present the arthroscopic technique of correction of posteromedial tibiofemoral incongruence, PMTFI, which is called also a came of the knee. Beyond the standard portals, 3 additional are needed. The procedure starts with a transnox maneuver. The surgeon makes a posteromedial portal using a needle followed by a surgical knife. Now it is a view from posteromedial portal. Through a medial parapatellar portal, a shaver is inserted. Medial part of the septum is being removed. Through the same transnox maneuver on the lateral side, posterolateral portal is being made using a needle followed by a surgical knife. The scope is transferred to a newly made posterolateral portal. The ablation probe is inserted through medial parapatellar portal and it is used to make a perforation, removal of a lateral part of the septum, which is seen as a bigger aperture. A correct, concave shape of metaphysis proximal to the posteromedial part of the medial femoral condyle MFC is visible in MRI and marked with the green color. Under visual control from posterolateral and transeptal portals, the knee is flexed to 90 degrees and then maximally. The free space for medial meniscus, the black triangle, is visible, so in this case there is no incongruence. However, in case of insufficiently concave shape of the area, incongruence in maximal flexion occurs. During maximal flexion, the clicking sound is hearable, caused by the meniscus subluxation. MRI shows an anatomical variability of metaphysis proximal to the MFC, marked with a green line. On MRI performed in full knee flexion, the meniscus is being crushed by insufficient concavity in the place marked by the circle. Now the knee joint is being fully flexed and the space closes completely. Conjoint insertion of the joint capsule and medial gastrocnemius tendon is being partially detached with the ablation probe under visual control. Then, with use of the arthroscopic burr, the metaphysis proximal to the cartilage on the posteromedial part of MFC is deepened. Through posteromedial portal, a switching stick is being inserted to change portals, encompassing better visualization of all parts of posteromedial tibiofemoral incongruence. With use of the arthroscopic burr, the most laterally extended part of impinging bone near the posterior part of intercondylar notch is being corrected. Subsequently, the surgeon returns the scope to posterolateral portal to check if there is enough of free space for medial meniscus during complete knee flexion, and we can see no incongruence. It is seen that the proper amount of the bone was removed, so the medial meniscus is not compressed. In the operated case, there are no signs of the incongruence, no clicking sound, and any other problems as soon as after 8 weeks from the surgery.